Hi all, welcome to Inspired Surgeon. Today we are going to discuss about microbiology related university questions. Disclaimer is given in the description box and watch this video at 1.25x. Let's move on to the video. First, I want you to remember there are some images are taken from the Google. I want to compile everything and give it to you. So this is a very important mnemonic. For anything they ask about Enterobacteriaceae, remember this point, E. coli, it's called IMBIC test. I am giving 5 points for each question. So IMBIC test is nothing but it's an enrolled red and with box proscar. It's an enrolled test, methyl red, box proscar and citrate test. So indole test in the sense E. coli can produce indole, which is plus. Methyl red indicates pH of culture if below 4.5 it is positive. Box proscar reaction depends on production of acetyl methyl carbonyl, then it is positive. For citrate test, utilization of sodium citrate as a source of carbon, Klebsiella positive. So just remember this point. IMBIC for E. coli is plus plus minus minus. For Enterobacter, minus plus plus. So for any urine related UTI infections, you must do cystoscope, ureteroscope, urine analysis, urine culture. Treatment, nitrofurantoin, antibiotics. Right. Then, so this is what I already said. E. coli, Enterobacter, Klebsiella, Proteus mirabilis, Proteus vulgaris. For Proteus vulgaris, it's similar to E. coli. Indole, methyl red positive. Box proscar, citrate negative. Right. And in case of Proteus mirabilis, it is methyl red and citrate positive. That is only difference we can able to differentiate it from Proteus mirabilis and Proteus vulgaris. Enterobacter and Klebsiella is similar. Indole, methyl red negative, box proscar, citrate positive. Right. Move on to the next question. Sometimes they will ask you about culture media. Just I want you to remember some basic points. Pseudomonas, that's predominantly on cetrimate agar, where we know that it is producing green color colonies. Staph aureus, it's a coccus, so it's a gram positive coccus baseless. So thereby it will produce golden yellow colonies. So just remember this. We are having the chains like in a golden, like this gold chains will be like in a rounded configuration, right? So just remember this, golden yellow colonies with yellow zone. So it will be mannitol agar medium, right? For E. coli, it is McConkey agar medium, just nothing but lactose fermenting medium. Yes. Klebsiella, it is pink colonies. E. coli, it is red, brown, small colonies will be there. Right. Now, that is, if they are asking you a question about E. coli, there are many things are there. Just remember this: entero-aggregative E. coli, entero-hemorrhagic E. coli, enterotoxigenic E. coli. So this one point you have to remember. So in this, I just want you to remember this. UT predominantly, the main point we have to remember is enterohemorrhagic E. coli. The strain which is called as H7O157 strain. So this is enterohemorrhagic E. coli strain, and this strain is responsible for hemolytic uremic syndrome. So patient is having dark color urine and patient is having associated UTI infections. So it is how the UTI progresses to the bacteremia. The one point I wanted to remember, First, contamination of the periurethral area, colonization of urethra, migration to the bladder, and there form the biofilm. Biofilm formation is an important nidus of infection. The very important is epithelial damage, from there ascending to the kidneys, and there it will forming bacteremia. Right. So there are certain viruses, they contribute to oncogenes. So in this, I want you to remember 3 points. First, name of the virus and what cancer it will cause. So as far we know, human papillomavirus will cause genital warts and it may cause cancer. Hepatitis B virus infection, which will cause hepatocellular cancer. And in this, there is one glitch: hepatitis B, hepatitis C. B is DNA virus, C is RNA virus. So these 3 things you must remember. So here there is a DNA virus oncogenesis. So always, if any oncogenesis, just remember these 2 things: retinoblastoma gene, p53 gene. So this p53 gene and retinoblastoma gene, these are tumor suppressor genes. So if there is a mutation happens, if tumor suppression is inhibited, then tumor occurs. If oncogene tumor activation occurs, now it is tumor formation happens. So that's how inhibition of tumor suppressor genes, which is RB gene and p53 gene, and lack the viral oncogene. Oncogene activation leads to tumor formation. Oncoproteins interact with the specific targets on the host cells. So as I already said, human papillomavirus, which is a DNA virus, causes transformation in cells. Then Kaposi sarcoma associated virus, or HHV8, is associated with the Kaposi sarcoma, a type of skin cancer. Epstein-Barr virus infection or human herpes virus type 4 is associated with 4 types of cancers, predominantly nasopharyngeal carcinoma, and it's also known as kissing disease. There is another thing called as Merkel cell polyoma virus. So polyoma, oma is a tumor, so causing Merkel cell carcinoma. Cytomegalovirus infection causing mucoepidermal carcinoma, which is human herpes virus type 5. So in nutshell, human herpes virus 4, 5, 8, which is Epstein-Barr virus infection, which is causing nasopharyngeal carcinomas. Human herpes virus type 5 is causing Merkel cell cytomegalovirus causing mucoepidermal carcinoma, and human herpes virus 8, which is your Kaposi sarcoma associated viruses. So this was causing Kaposi sarcoma. There are certain viruses which are oncogenic RNA viruses. So these retroviruses are oncogenic RNA viruses, and they are dividing into onco and lentivirus. Right. Oncogenic DNA viruses, hepatitis B, herpes, and papilloma viruses. So papilloma, which is human papilloma virus, herpes virus, as we already said, human herpes virus 4, 5, 8. 4 is EBV, nasopharyngeal carcinoma. 8 is Kaposi sarcoma. 5 is cytomegaloviruses. Oncogenic viruses. So papilloma virus, these are family virus. Herpes virus, human herpes virus 8, and Epstein-Barr virus, which is human herpes virus type 4. Human papilloma virus, Papoviridae. Hepatitis is hepatitis B virus. RNA viruses is a flavivirus. Flavivirus is hepatitis C virus. Retroviruses, human T-cell lymphotrophic viruses. Human T-cell lymphotrophic viruses are nothing but retroviruses, causing adult T-cell leukemia. These are human T-cell lymphotrophic virus. Hepatitis C virus causing hepatocellular cancers. Right. Helicobacter pylori. I just want you to remember three important points in this Helicobacter pylori. So first point is gram-negative bacteria. There are two toxins, VAC-A and CAG toxin. These are mainly responsible for gastric cancer. They survive at pH less than 2. And Helicobacter pylori is a twisting motility or a spiral motility. The patient is like that. And with respect to the culture medium, it is Duke's medium and H. pylori regimen, we all know. So that is a very important point. Now we go into the discussion. H. pylori, a gram-negative spiral rod. So it is having unipolar tuft of flagellum. So transmission wise, oral, fecal-oral transmission. So it will cause duodenal and stomach ulcers and gastric adenocarcinoma and lymphoma. So very important is how do they maintain the pH which is less than 2? And they are urease positive organisms. So they will divide the urea and thereby they will maintain the pH. And these organisms also possible cause stomach cancer mechanism. The mechanism, as we said, CAG and VAC-A toxin. So there are two antigens, O antigen and H antigen is present. And this is H, and very important is urea breath test. Urea breath test where we can able to have a radio label CO2. This is important. And you are having amoxicillin, bismuth subsalicylate and metronidazole for 2 weeks. Next. With respect to gas gangrene, I want you to remember 5 points. So what are they? It's a Clostridium myonecrosis. So pathogens, the Clostridium is a gram positive anaerobic organism. Right. So crepitus is a very important clinical feature. Predominantly gas gangrene occurs in situations like diabetic foot, gunshot wounds. So treatment phase, anti-gas gangrene serum. They can be given. So let's move into this. And if the myonecrosis happens, there will be hyperkalemia. It will be causing arrhythmias. And because of this myonecrosis, there occurs myoglobinuria, and that will be causing kidney injury. So these three things are you must know. Let's move on to the para discussion. Gas gangrene, a rapidly spreading edematous myonecrosis. Pathogenism, Clostridium perfringens. So it's a disease of war, as already seen, gunshot wounds, and also heavy contamination. So there are 3 types of anaerobic contamination: simple wound contamination, anaerobic cellulitis, anaerobic myositis. So next, very important point, gas gangrene is a Clostridial multiplication when low oxygen tension, extravascular hemoglobin and myoglobin are reduced, and sees they act as autocarriers. So now Clostridium multiply and elaborate the toxins that will cause further tissue damage. As I already said, tissue damage happens, potassium, and that will cause cardiac arrhythmias will be there, and also there will be myoglobinuria causing kidney damage. Profound toxemia and prostration develops and death due to the circulatory failure. So there is a signs of sepsis will be present. So the diagnosis is mainly by gram-positive bacillus with subterminal spores. So subterminal spores in the sense it will be like this. We're having the spores which is a gram-positive bacilli, a subterminal spore. All anaerobic organism, the only one culture media is Robertson cooked meat medium or even a candle jar medium. This is a very important medium for all anaerobic organisms. These organisms tend to produce coagulase and hyaluronidase, and they will cause a double zone of hemolysis. Right. So for anaerobic infection, we can go with metronidazole given IV and repeated 8 hourly for 24 hours. Anti-gangrene serum is given. Right. So what do you mean by tumor antigens? So when tumor antigens, so these are carcinogenic antigens. So just remember this. So when the cell undergoes a malignant transformation, it acquires new surface antigen, and they may also lose some antigens, making it antigenically different from the normal tissues of the host. So tumor antigens are antigens that are present in the malignant cells but are absent in the corresponding normal cells of the host. And this is very important. I have to emphasize this. There is another one called as tumor-specific transplantation antigens. These will induce rejection of tumor transplants in immunized host. So in chemically induced tumors, the tumor-specific transplantation antigens are tumor-specific, and different tumor may possess different, even induced by the same carcinogen. So one example is alpha-fetoprotein in hepatoma, carcinoembryonic antigen in colonic cancers, prostate-specific antigen in prostate cancer. So just remember this my point. I want you to remember tumor antigens are malignant antigens. Malignant cells are not present in the normal cells. Second point, tumor antigens are nothing but alpha-fetoprotein, carcinoembryonic antigen. So this alpha-fetoprotein, hepatoma, carcinoembryonic antigen, embryonal cancers or colonic cancer, and prostate-specific antigens are prostate cancers. See, the point I wanted to remember is prostate-specific antigen is not specific to prostate cancer alone. It is specific to prostate, but it is not specific alone to cancer. It may be elevated even in BPH, prostatic infections also. So this is very important with respect to tumor antigens. Methicillin resistant Staph aureus. Remember 5 points. Staph aureus is a gram-positive aerobic coccus. As we previously discussed, Staph aureus is mainly producing golden yellow colonies. So in Ludlam's medium, it will produce oil paint appearance. So it will be having golden yellow round colonies. As I said, Staphylococcus aureus. MRSA, Ludlam's medium, oil paint appearance. So they produce coagulase, protease, hyaluronidase. And there are very important toxins, hemolysins. As we said, Clostridium perfringens produce double zone of hemolysis, which is called as Nagler reaction, as we know this in microbiology, Nagler reaction. Now here, toxins that are hemolysin, alpha, beta and theta toxin. Toxic shock syndrome toxin, enterotoxin, exfoliatotoxin. Each has its own thing. Toxic shock syndrome, sepsis, exfoliatotoxin, epidermolysis, causing bullae, enterotoxin causing diarrhea. So treatment is benzalpenicillin was initially given in the strain which is MSSA. if it is MRSA, now we have to go for vancomycin. Right. So just I want you to remember methicillin, which is due to limitations in the clinical use of methicillin, cloxacillins are used instead against penicillinase producing organisms. Methicillin was the first compound developed to combat resistance to penicillinase, which is beta-lactamase production by the staphylococcus. Right. So now MRSA resistant not merely to penicillin but also other beta-lactam antibiotics and other medicines. So now vancomycin is the drug of choice. So beyond methicillin, what are all the other drugs that is just remember this mnemonic. For MRSA, we can go with drugs like condom. So what are all the penicillinase resistant penicillin group of drugs, which is condom, which is cloxacillin, oxacillin, ampicillin, dicloxacillin, oxacillin and methicillin. So this is very important if they ask you question about penicillin in pharmacology. The mnemonic is condom, cloxacillin, oxacillin, ampicillin, dicloxacillin and oxacillin and methicillin. Okay, and now I want you to remember the drugs that are effective against MRSA beyond vancomycin. So vancomycin is the drug of choice for MRSA. Other than MRSA, what are all the drugs that we can use? Just remember this mnemonic: B, C, D, which is nothing but daptomycin, clindamycin, bacitrazine. So these three drugs are very important and responsible for effective against MRSA. There are certain drugs which is topical applications are not used systemically. As I said, B, C, D, clindamycin and doxycycline and daptomycin for MRSA, and bacitrazine is a preparation which is a topical application, not a systemic. The carriers are very important to treat. Is by local application suitable antibiotic like bacitrazine. In resistant cases, rifampicin along with oral antibiotics may be effective in long-term complication or elimination of a carrier state. So for MRSA, the point we have to remember here is, in nutshell, MRSA 5 points we have to remember. For penicillinase producing strains, which is condom, cloxacillin, oxacillin, ampicillin, dicloxacillin, oxacillin and methicillin. MRSA, the point, a gram-positive aerobic infection. It's a bacil, it's a coccus. So methicillin resistant, in that sense, what antibiotic I should prefer? Vancomycin, BCD, daptomycin, doxycycline, clindamycin, bacitrazine. And very important point I want you to remember: MRSA, golden yellow colonies and Woodlamp's medium oil paint colonies are present. So they will cause toxic syndrome toxin, enterotoxin causing diarrhea, and exfoliative toxin, which is epidermal lysis. And now we are dealing about tetanus. So just remember 3 points. It's caused by Clostridium tetani, which is a gram-positive aerobic organism. So tetanus, as we all know, it is having 3 points: opisthotonus, rhizus sardonicus. So for tetanus, I wanted to remember 5 points. As I already previously said, opisthotonus, and rhizus sardonicus. So, what do you mean by opisthotonus? Just split the word opisthotonus. So, tonus is the posture of the body. How does the posture will be there? It will be like a bending of the patient, which is hyperextension. What is rhizus sardonicus? Is nothing but your larger. How does it happen? Just remember these 3 points. Tetanus is caused by Clostridium tetani, which is a gram-positive aerobic organism. So, gram-positive anaerobic organism. Sorry. So, tetanus, a very important thing. It releases, is mainly Clostridium tetani releases tetanospasmin. Tetanospasmin inhibits the release of inhibitory neurotransmitters, which is your glycine and GABA. So, if there is no inhibition, if there is no inhibition, there will be local excitation that will happen. Remember this, if there is inhibitory neurotransmitters or inhibited, there will be local excitation, and because of that there is hyperextension, lockjaw, rhizus sardonicus, all these things will happen. So, we know that TT vaccine should be given. How and how periodically it is given will be discussed at the end of this question. So, first point is, this Clostridium tetanus spores are predominantly present in the soil. So, it is present in cotton, wool, street, everywhere. Tetanus is characterized by tonic muscular spasm, and initially at the site of infection, then it will become generalized. The spores contaminate the wound. Like predominantly we know, umbilical stem is packed with mud. So this is a very important lead to infantile tetanus and causing lockjaw. So this will predominantly basically releases the tetanospasmin toxin. Tetanus is then transported through the nerves, synapses and the CNS. The patient experiences spastic paralysis, the complete spasm of the muscles. It's a muscle contraction that cannot be stopped. So diagnosis, it's a terminal spore, and it is called as drumstick appearance is present. So you can do immunization. So routine. So in adults, the dose of tetanus toxin is recommended every 10 to 12 years. There is another one thing called clostridial antitoxin, which is nothing but anti-tetanus serum or TET glow, that can be given to boost the passive immunity in cases of where no protective antibody is found in an individual. So this is a very important table. Just remember this point. If patient is immune, if it is a clean wound,